Hi, I am Dr. Manjunath. I'm a pediatrician and allergy and asthma specialist based in Bangalore. Today we have a couple of concepts to be discussed in the respiratory physiology. We will not be going everything of it. We will be dealing only a few of them. The most important thing, the learning objectives for today will be let's understand how the system works, have the clinical applications to be in place once you have learned the system working, and then we will summarize all of that at once. There are many functions what a lung does, but the most important of that is to allowing the lung air to come in and out of lungs, and second is to have the gas exchange from the lungs. These are the two main things. Despite all the functions what the lung does, these are the two main things what our lung does. For the muscles of the respiration, there are scalenes, the sternomastoids, internal intercostalis, external intercostalis, serratus anterior. But the most important of all these muscles are the diaphragm and the external intercostal muscles. Coming to the movement of the chest wall, there are two types of movement what we see on a regular basis. One is a pump handle movement and the bucket handle movement. Pump handle movement is like up and down movement of the chest wall, which happens between the 2 and 6th rib cage. That allows the anteroposterior expansion of the chest wall. Whereas the bucket handle is when the chest is moving sideways, as if akin to the bucket handle movement. So this way it allows the sideways expansion of the lung, allowing more and more expansion of the thoracic cavity. There are basically 4 lung volumes and 4 capacities. The tidal volume is the regular effortless breathing what we do on a regular basis. In adults it's about 500 ml. And the inspiratory reserve volume. At the end of inspiration, you take the largest amount of volume what is possible, that is the inspiratory reserve volume. At the end of expiration, you try and breathe out the maximum, that is the expiratory reserve volume. Whatever the volume of air which is left at the end of breathing, that is the residual volume. When you try and add on the various volumes, it becomes the capacities. For instance, inspiratory capacity is a combination of the tidal volume and the inspiratory reserve volume, which is about 300 ml in a normal adult. Functional residual capacity is about 300 ml. That is a combination of expiratory reserve volume and the residual volume. And the vital capacity is about 4.5 ml. That is everything included except the residual volume. When you add up all the volumes, it becomes the total lung capacity. There are some age-related changes, like the infants and toddlers have significantly lower lung volumes and capacities. For example, the tidal volume may be around 20 to 30 ml in an infant, and in a school-age child, it increases these lung volumes and capacities increase steadily, reflecting the growth in the body size and the lung development. By the late adolescence is when the lung volume reaches to that of the adult. And if you see the differences between the spirograms, there's a lot of difference between an adult and a pediatric spirograms. In an adult, they have higher peaks and deeper troughs, reflecting larger lung volumes and capacities. A child has shorter peaks and shallower troughs, representing the smaller lung volumes and capacities. A normal spirogram of a child is smooth, well coordinated effort with rapid rise to peak followed by a gradual decline, which is a little different from an adult spirogram. We speak about the efficiency of the lung. The question what we are trying to answer is this: is lung really that efficient? We'll take some examples. For instance, kidneys. The small size relatively, and they exchange a lot of blood volume every day. They consume about 10% of the total resting energy needs. Brain, which is about 2% of the total body weight, consumes about 20% of the resting energy needs. Whereas your lungs, the honkingly big, exchanging about 11,000 liters of air every day, just needs about 2 to 5% of the resting energy spent on a breathing on a regular basis. You can imagine how efficient the respiratory system is. The lung basically works in a perfect equilibrium between inspiration and expiration, and that point where the equilibrium is maintained is the functional residual capacity. By definition, it represents the volume of air remaining in the lungs at the end of normal passive exhalation, which is roughly about 3 liters and weighing about 3 grams. If you take per kilogram, it is about 35 ml per kg body weight. You must remember one thing, and that is it's only the inspiration which is taking a lot of energy. The expiration is basically passive, which is matched at functional residual capacity. See, your diaphragm and the external intercostal muscles work hard to expand the lungs, and the elastic recoil and the surface tension of the lungs pull back the lungs to its original shape, and this balance is FRC, which we have been talking all along. It does so many things. That is, it prevents the alveolar collapse. It gives you the splinting of the alveoli so that it doesn't collapse. It creates the reservoir of air and thus ensuring the gas exchange. It also gives you the optimal lung compliance, and it also gives you a buffer against the changes in the blood gases. If you look at the physics of the functional residual capacity, it is the pressure from the air outside the body, generally considered to be about 0 centimeters of water, which is about 760 millimeters of mercury at sea level. And the intrapulmonary pressure, which is again taken as 0 centimeters of water. That's again at the level of the 760 millimeters at sea level. Then where is that gradient? That gradient is established in the intrapleural space, which is roughly about -4 centimeters of water or -4 millimeters of mercury. So this gradient oscillates between 4 and 6 millimeters during the inspiration and expiration. So they are perfectly matched again at the functional residual capacity. At the end of inspiration, when the lung reaches its maximum capacity, the elastic recoil forces of the lung pulls it back to -4 pressure. What was -6 at the end of inspiration comes back to -4 at the end of inspiration. So that's how these things are fully measured and balanced. And whenever these things, there is any small difference in any of these pressures, are going to affect the lung volumes and capacities, and so this is the functional residual capacity. There are some factors which can affect the functional residual capacity. It is higher in an upright position compared to the lying down. Lung and the chest wall compliance changes in the compliance of the lung. For instance, if the lungs are very tight, which happens in a restrictive lung disease where the lungs just do not expand, and even if they're expanding it very difficultly. In a very, it becomes hard, and that is the FRC decreases. In a situation like an asthma or a COPD, where the lungs are in a permanent state of inspiration, and that leads to floppy lungs, leading to the increasing in the FRC. Same thing happens even in old age, where the functional residual capacity increases. That is because the elastic recoil forces of the lung come down. The elasticity of the lungs are decreased to an extent where the lungs are in a state of permanent expansion. And some other factors like the weakness of the muscles, as seen in the neuromuscular disorders, can also affect your functional residual capacity. Let's see some of the clinical implications. We have been speaking about this transpleural pressure, which is about -4 millimeters of mercury or -4 centimeters of water. There are some conditions like the pneumothorax, hemopneumothorax, and pneumothorax where this pressure is lost, and the pulmonary pressure and the atmospheric pressure becomes at 0. There is no transpulmonary pressure, resulting in this 760 millimeters of mercury pressure. Just when it presses on the lungs, the lungs just collapse. They go for atelectasis, collapse. They also go to an extent where they can even be pushed to the opposite side, causing the mediastinal shift. And in the mechanical ventilation, positive end expiratory pressure is often used to maintain the positive airway pressure at the end of expiration, thereby increasing the FRC and preventing the alveolar collapse. And in obstructive lung diseases, again your FRC is increased, and in your restrictive lung diseases like in pulmonary fibrosis, FRC is reduced to a large extent, which we discussed earlier at all. And another important concept what we need to understand is the closing capacity of the lungs. The volume of the air in the lungs, with which the smallest airways, the terminal bronchioles, begin to close during the expiration, is the closing capacity. The closing volume is the volume of air that can still be exhaled after the small airways begins to close, is the closing volume. And the residual volume is the amount of air remaining in the lungs after a maximal exhalation. So that means your closing capacity is residual volume plus the closing volume. This can be very well depicted in this photograph, in this image. The airways are pulled open by the traction from the neighboring alveolar septi. With expiration, the traction decreases and the alveoli starts decreasing in its volume. The small airways decrease in diameter as well. The closing capacity is the lung volume at which these volumes collapse completely, causing a small airway collapse. There are many factors which can influence the closing capacity, and that is the age, the body position, the lung disease, and even the smoking. With increasing age, your closing capacity increases. At the age, by the time a person reaches its 40 years, the closing capacity matches to that of the functional residual capacity. So atelectasis starts happening by the age of 40 years. And by the age of 65 years, many of the closing capacity is almost equivalent to that of the functional residual capacity. Even in sitting position, many of the alveoli starts collapsing. And the lung diseases like the COPDs, pulmonary diseases, emphysema can increase the closing capacity due to the loss of the elastic recoil and the airway support. Smoking is another important thing what need to be kept in mind. Can lead to airway inflammation, remodeling, and the increasing closing capacity. As we have been discussing about the clinical implications, gas exchange is greatly affected whenever the closing capacity increases. It can lead to ventilation perfusion mismatch and the impaired gas exchange, contributing to the hypoxemias. Increasing age increases the risk of atelectasis and the impaired gas exchange, especially during sleep or when they are in lying down position. And in surgery and anesthesia, we need to be very careful about what the functional residual capacity and the closing capacities are before we embark on surgeries and other things. Lung compliance, it can be defined in two components. One is a static compliance and a dynamic compliance. Static compliance reflects the elastic properties of the lung and the chest wall without the influence of the airway resistance. And the dynamic compliance is when you include the airway component. Lung volume, elasticity, surface tension, and the chest wall mechanisms can influence the compliance of the lungs. With a decreased compliance, like in fibrosis, pulmonary edema, and ARDS and atelectasis, the compliance is greatly reduced. And the increased compliance happens in the loss of the elastic fibers in COPDs and in the age. Airway resistance is another important component of the lung physiology which we need to understand. The diameter of the lung, the length of the airway tonality, obstructions, volumes, and lastly the density and the viscosity of the air also play a huge role in the airway resistance. Upper airways contribute to about 25 to 40%, 25 to 40%. The trachea and the main bronchi about 10 to 20%, and the bronchi and the larger bronchioles about 40 to 60%. So that means the smaller bronchioles and the terminal bronchioles contribute to less than 20% of the airway resistance. So please remember, resistance is a frictional force. Another important concept what we need to understand is the dead space. The portion of the respiratory system where the gas exchange doesn't happen is the dead space. There are two types of it. One is the anatomical dead space and the physiological dead space. The air present in the conducting airways such as the trachea, bronchi, and the bronchioles contribute to the anatomical dead space. The volume of air what goes inside of the lungs, they just do not participate in the lung exchange or the gas exchange. And the physiological dead space is the anatomical dead space plus any alveolar dead space where the alveoli are ventilated but are not perfused with the blood. This happens mostly in the apex of the lung. So we need to have a importance in the understanding of what it is, that it influences the efficiency of ventilation, the ventilator management strategies, and the positive end expiratory pressures. All these need to be kept in mind whenever you are trying to ventilate a person. So anesthesia and critical care, it becomes a very, very important component. So monitoring of the dead space is important in critically ill patients and during anesthesia to ensure effective ventilation and oxygenation. And in capnography, that is measuring the end-tidal CO2, provides an indirect assessment of the dead space. A significant gap between the EtCO2 and the arterial CO2 suggests that there is increasing dead space. Alveolar ventilation is like when the alveoli, alveolar sacs, alveolar ducts, and the respiratory bronchioles are aerated, involves in the gas exchange. These are the only areas where the gas exchange happens, and this is the alveolar ventilation, which is the reverse of the dead space. There are See, patterns of your breathing can influence your alveolar ventilation. Rapid shallow breathing increases the dead space because a lot of the gas comes and goes without participating in gas exchange, whereas slow deep breathing decreases the dead space and increases the effective ventilation part. We must also need to understand the west zones of the pulmonary perfusion. Starting from the apex of the lung to the base of the lung, the perfusion starts increasing. The apex of the lung, the lungs are less perfused, and in the base of the lungs, they are more perfused. That is, the gravity, pleural pressure, and the hydrostatic pressures play a huge role in the zones of the pulmonary perfusion. Zone 1 is the apex of the lung, where the alveolar pressure, arterial pressure, and the venous pressure are in the decreasing order. This results in limited or no blood flow because the capillaries are compressed by the higher alveolar pressure. It can occur in conditions like low blood pressure or positive pressure ventilation. Zone 2 is the mid lung or the arterial pressure, where the arterial pressure is more than the alveolar pressure, which is more than the venous pressure. Zone 3 is the arterial pressure is more, the venous pressure is also more, and the last will be the alveolar pressure, that is the PA is greater than the PV, which is greater than PA. This allows for the continuous blood flow to the pulmonary capillaries. Zone 4 is occasionally described where the pressure relationships of, that is the interstitial pressures, may play a huge role. It is mostly described in pathological conditions like in the ARDS, pulmonary edema, and the interstitial lung diseases. See, understanding of these west zones are very important in the ventilation perfusion matching, the effects of positioning, like the positive pressure ventilation. If you are doing it and if you are giving a lot of pressure, this potentially converts the zone 2 regions into the zone 1, affecting the blood flow and the gas exchange. And they are also affected in the some of the pulmonary pathologies. Another important concept what we need to understand is the ventilation perfusion mismatch, where there are basically two types of ventilation perfusion mismatch. One is a shunt, another one is a dead space. There are some conditions where the perfusion of the lung is unaffected, whereas the aeration is affected, which is like a pneumonia or a ARDS or a pulmonary edema. The blood comes to the lungs without having any gas exchange, it comes down. That is the intrapulmonary shunting. And it is also called as a low VQ mismatch. When there is a lot of dead space, that means the blood is not reaching the lungs. This is also called as a high VQ mismatch, which is basically the reversal of the shunting. This can happen in case of a pulmonary embolism, where the aeration is unaffected, whereas the blood circulation is affected. I think this will be the end of most of the respiratory pathologies, the physiology part of it. See, a thorough understanding of the physiology is needed to understand what the pathology of the lung is and how they would interact with each other during the pathologies. So, if there are any queries, if there are any discussions to be made, please submit in the chat box. I'll try and answer as much as I can. Please like the video, subscribe to my channel, and also spread this to your postgraduates and those who are interested in the respiratory physiology. Thank you.